I'm Claire Stevens. I'm the co-clinical director of the North Central London Cancer Alliance, and I'm here with our team today and with 3 invited guests talking about cervical cancer. And our focus today is on screening. So I'd like to introduce our 3 speakers, and I'm going to ask them to give a couple of sentences about themselves when they start to speak. So, and we'll do that in a minute. It's Tatjana, Dinah and Hannah. Tatjana is a practice nurse, and we in fact worked together for many years in a practice where I worked for 22 years, I think, Tatjana, wasn't it, in north of our patch, in the north part of NCL and Barnet. Dinah is a CNS specialist from in UCLH, specialising in colposcopy. And Hannah Dwyer comes from Joe's Cervical Cancer Trust, so she'll be giving us, hi Dinah, thanks for the perspective from the charities. If we could just go to the next slide. So I just wanted to, we usually start with a single slide explaining a little bit about who we are. So we're the North Central London Cancer Alliance. We're one of 21 cancer alliances in England, and we're focused on meeting the national targets for early diagnosis and treatment. We're particularly interested in developing pathways for treatment, supporting research, development, and championing the innovation of practice and providing tailored care. We cover our 5 boroughs of NCL, and our partners are, of course, yourselves, patients, hospital trusts, GP practices in their totality, healthcare commissioners, councils and charities, not in any particular order, of course. And as an NHS organisation, the important thing to be aware of is that we're here to transform and improve healthcare strategy and the organisational system changes that are needed to deliver those priorities. I think we'll go to our next slide, which is just a slide that many of you will have seen before, but it's really helpful visually. And that yellow, coloured yellow area was the shortfall of our first treatments in cancer at around Christmas time, and the autumn winter of last year, and Christmas into the new year. And that really meant that COVID has delivered for us a reduction in cancer diagnostic rate of well over 900 cancers for patients and residents in North Central London. That was significant, and that was because of a mixture of things, principally people not coming forward when they had symptoms, patients feeling that they didn't want to bother the NHS, patients not being able to be referred on in a timely manner because the whole of the hospitals had to refocus their healthcare on ITU and acute COVID. And also, we stopped at the guidance of NHS England, we stopped screening across the whole of the country in April 2020, and we restarted screening in a staggered way in late summer. And that reduction in screening across all our screening modalities really affected our pickup rates. So we're here now, nearly a year on, in a slightly different environment. We're catching up slowly on our missed cancers. Our screening programmes are catching up at different rates, but they are catching up. And certainly in terms of cervical cancer, we've now managed to get to resolve the backlog that we had that was delivered to us in the 19-20 year because of COVID. So that's fantastic. But we still need to do more, because you'll remember that all of you that our levels of cervical screening in London and nationally are not as good as they should be, but particularly London has a problem, so we need to improve. If we move on to the next slide, I just want to 1 or 2 little housekeeping rules. So please, thanks, as you've already done, keep yourselves on mute. Do post questions in the chat. We are recording this session so that if you want to, you can go back to it at a later date, and you can find it on our YouTube channel, or you can share it with your colleagues. And we'll post a feedback survey at the end of the session. Please do fill in anything you want to there, and that helps us craft meetings going forward. So thanks very much to everybody, and let's move through to Tatjana. I've asked Tatjana to speak first. Thanks, Tanya. And from a GP perspective, a practice perspective, thanks very much.
Yeah, thank you. I would just need kind of my slides to come up if that's okay, so I don't have the control of them.
Sure, we'll bring them up for you.
Thank you.
Is that Catherine or Amanda who will help us with that?
Yeah, Amanda is bringing up the slides, I believe.
Thanks so much.
It's me. Sorry, my computer's a little bit slow.
No, don't worry. So while we're waiting for that, many of you will recognise Tanya from one of our videos that we put together some time ago, trying to explain to patients what it would look like when you came for a smear and the sort of PPE that people were wearing. So thanks for helping us with that at that time, Tanya. Here we are. I think here are your slides. So I think if you could put them into presentation mode, Amanda, that'd be great. Like your pink colouring.
Oh, well, it's got to be pink for the smears, doesn't it?
Fantastic.
Thank you.
Okay, thanks very much. Off you go, Tanya.
Okay, so my name is Tanya. Thanks, Claire. I work at the Speedwell practice. I'm just one of the nurses here. So I've been asked to kind of give the nursing perspective on all these subjects. I've been a practice nurse for about 2.5 years, and the kind of disease prevention has always been my passion. So if I can have the next slide, I've got my little prevention is better than cure. So this is kind of what has made me move from secondary emergency care into primary care. I just thought I could do more on this side of the fence. And screening in particular has been very dear to my heart, because from the personal reason where my sister came very, very close to having cervical cancer, and it was only pretty much due to my nagging that she has gone to have it done, and we caught it on time. And then during my training, I had another lady who was very, very similar, 33, with an 11-month-old son, who's never had a screening before. And I've managed to kind of convince her to have it done. And as soon as I saw her cervix, I knew something wasn't right. She did came back later. She had a treatment and she came back later. She was extremely grateful for convincing her. So that just kind of really cemented to me how important cervical screening is, and kind of to take every opportunity to speak to our ladies and convince them to have it done. So really, what is our biggest challenge, really? And is like we can see, 1 in 4 women don't attend. That goes to 1 in 3 in a younger generation. I do try to kind of drum it in a little bit to them that it's really heartbreaking that 2 women will still die every single day from cervical cancer. It being a preventative disease, we could stop that. So that is kind of what I think is one of our biggest challenges in primary care. And if you go to the next slide, we have a few, not excuses, but a few of the reasons why women say that they're not coming in. Anything from worrying that's going to be painful, that they're uncomfortable getting undressed in front of a stranger, that there are heard horrible stories about things, and the embarrassment. There's cultural issues there as well. So, and it's really kind of interesting that 33% wouldn't go if they haven't had their gardens sorted. And we always say we really, really, really do not care how your gardens look like. Just please come and see us. Okay, so basically now I would like to say, what do we do at Speedwell? So before the appointments, I always get all of my stuff ready so that I don't have to keep on running around, get everything in one room, get my room ready. I've got my little, what I call my little knicker box. I have my little plastic box with a lovely little picture of knickers on it, and that gets clean in between every patient and covered with a clean sheet, and just kind of be prepared for what I'm about to see. So that will be checking the open exeter, making sure when was the last appointment, because that will be needed for the form anyway, and just to check if there is any previous abnormalities. I can check the letter from colposcopy and kind of be prepared so I know what's going on and be ready in that way. So then the next slide will be said that what happens during the appointment. So I think the number one is really, really important. Establishing a good rapport with ladies, it's vital. And that is especially important if they're having the first cervical screening. So being friendly, reassuring, inviting, smiling, even though we are behind all these masks. Watch the woman, observe her body language, notice if there's any anxiety. I always try to break the ice with maybe a little bit of humor, kind of put them at ease. And the other thing I think is quite important as well is always thank them for coming. You know, to some of them it's taken a long time, a lot of thought, a lot of encouragement kind of to come and see us. And if they are coming on time, I always kind of really acknowledge that. I could say kind of thumbs up, gold star and all of that. And if they are late, you know, there is no judgment about it. Just kind of ask, you know, why? Because that could just be a little bit of a kind of being able to kind of find out why they're not here and maybe address it at this appointment. Okay, so the next one is kind of the important things to cover in that appointment, and that is that the cervical screening is a primary HPV screening. I always stress that we are not looking for cancer, we are looking for HPV. Explain to them what HPV is, how is it transmitted. Kind of there is so much myths and stigma about it of you know, if you're promiscuous, if you're dirty, all of those things that kind of the thing that, oh, that are you implying that I'm sleeping with many people and all that sort of thing. So try to kind of bust those myths and put that stigma to rest. Emphasize that it's a very, very common virus that lives on us, that 8 in 10 of us will have it, even we might not even be aware that we've had it and cleared it. There is no symptoms, there is no treatment, but 9 in 10 of us will get rid of it. Our immunity system will get rid of it without any problems, but I do stress that it can take up to 2 years, so that they are not surprised by that fact. Then the next point would be to explain any possible results, what do they mean, and how will they get it. Kind of the letter comes from the laboratory. That might take, you know, 2, 3, 4 weeks, depending on how busy the labs are. And in the pandemic, you know, the postal stuff was kind of slower as well. And in our case, we kind of tend to send them text as well once we receive them. So, and just kind of offer it up to a question, you know, have you covered everything? Have anything that you have said has kind of made any sense to them? Do they still have any questions? So we can have the next slide. And this is now the biggest problem. There's a lot to cover from our point of view, and there's a lot for them to take in, and all that in anything between 15 and 20 minute appointments. And this really doesn't even include the actual doing the smear. So if you are then faced with difficulty in finding a cervix, or the lady just can't relax, or you're having any issues or problems, then that just really overruns. So we have then decided, how do we address this? So we have then decided that we're just going to explain very basics about the HPV and the results. One of our doctors has pointed out that after about a couple of minutes in your appointment, patients stop listening to you. They can't take that. It's too much information overload. So we have devised, with the help of one of our senior nurse, Karen, we have made a double-sided A4 information leaflet. On one side, it gives them more about the results, how it works, the kind of flow chart of it. And on the other side, it has a link to Joe's Trust website and a little bit more information about the HPV. And I have recently found out that if there is a language barrier, that small.org.uk is a fantastic website that can help because they have the accessibility and language options, so that they can translate it there for them. So our little kind of piece of paper, I don't know if you can see, it's literally just one page results, and the other page is just a little bit more HPV, and the link usually are kind of color really nice little pink colors, so that kind of stands out. Okay, so if I can have the next slide, thank you. And then what happens at the end is that when we receive the results, obviously we document it, set the recall date for the next screening date, and then we have made a whole lot of templates so that we don't have to type everything out all the time, but informing the ladies of the results. So if it is normal, no HPV, then I'll just send a text saying, receive the results, everything is okay, you will be, you're due again in 3 or 5 years time, depending on the age. And then the way it's set up in a little pathway, about 4 weeks before they are ready to, they're due to have their screening again, they will receive a text message in 3 or 5 years time, as long as, of course, they stay on the same mobile number. So we have the links that we put in on all of those texts as well, so that the ladies can, and kind of point it out in the text as well if you need any more information. And for the abnormal ones, there is always that line as well. If you want to talk to or discuss anything to anyone, please call one of the nursing teams, and we'll be more than happy to talk to you and discuss it. And what I've learned very, very recently is never, ever, ever send a result that is abnormal on a Friday, because that will just create an almighty anxiety in ladies. Dr. Google will come to fore, and then by the time you come to work on Monday, you have many messages that they want to speak to you. They're really distressed. So even though you send links, you know, not everybody will read them. Sometimes we can give them all the links and all the information in the world. I know that the leaflet does come through even with a letter invitation, and even from Colposcopy, because I've spoken to Colposcopy. They said that they send a letter with information leaflets about HPV and everything. So unfortunately, not every woman's going to read it. So we do try to say everything as much as we can during the consultation, but with the time constraints and everything, it's not always possible to go deeply. I mean, we have run over, but that's normal. And then at the end, I just kind of wanted to point out our future of cervical screening, which I'm really, really, really excited about. So as you can see, there's a UScreen study that offers the HPV self-sampling to non-attenders. At the moment, it's anybody at the GP practice, anybody over 6 months overdue, at opportunistic level, we offer during any consultation that we have with them. And I mean, the 5 sorry, my mind's gone blank. The 5 boroughs that have been chosen are the kind of have a low screening coverage. So hopefully this will give ladies a choice. I have ladies who have, even though they've been offered, they have still chosen to have the full screening, which is absolutely fine. That's our gold standard. But I've also had ladies who we have been trying to get in for years and years and years, and they have finally managed to have it. And even our transgender population as well has kind of taken to it. So it's really exciting, and hopefully this will all work and make a little bit easier for the ladies. I think that's all from me. I think I've got one more little slide at the end. That's kind of a bit that we can all make a difference. So thank you very much for listening to me, and I'm more than happy to answer any questions if anybody has any.
Sorry, not following. I thought, thanks very much, Tanya. We'll move on through the 3 speakers and come to the questions at the end, I think. So that was really helpful, really interesting, and we might have, I know, questions about UScreen, and we'll cover those at the end. Okay, so if I can ask Dinah to come and speak to us. Dinah is the CNS at UCLH in colposcopy. Thank you very much for joining us today, Dinah. Are you sharing your slides, or would you like us to do it for you? Thank you. Thanks very much.
Dinah, you're on mute if you're speaking.
Hello there, sorry, can you hear me?
Yes.
Okay, great. My presentation is just regarding overview of colposcopy and what the patient should really expect in an appointment, and just quite the common queries that we really get on an appointment. I think it's important to highlight as well that with especially Tanya's presentation, it's also quite informative for me as well as a colposcopist, because what I've actually learned from yourself actually is that you do discuss quite a lot in your appointments, which is really good, really useful for the patients. But I do agree it's probably a very short amount of time to be able to discuss so much information. And definitely a lot of the patients probably don't take in as much information as what we would hope for them to take in. But I will just start with just explaining just a quick brief overview of what a colposcopy appointment entails. So I'll just move on to the first slide. So just to begin with, most patients start with having their smear test by the practice nurse at the GP. And if that result does come back as abnormal, the woman is referred directly for colposcopy, which we receive via a direct referral from the laboratory. And the reasons why they come for colposcopy is for us to have a more detailed and in-depth examination of their cervix to diagnose and determine what grade of abnormality they have on their cervix, and then from there to manage that type of abnormality by treating or monitoring. And next slide. Sorry, this is so small, tiny writing. So just to highlight how a normal, typical colposcopy visit would go. So when the woman comes into colposcopy, usually they're seen by a nurse colposcopist or a doctor. I have sort of highlighted that a nurse colposcopist actually provides the same examination that a doctor does, because quite often when patients come in, they often think if they're seeing a doctor that things are much more worse, or sometimes they do question if they're seeing a nurse colposcopist as to whether they're receiving the same level of care. So just to highlight to them that a nurse colposcopist does do the exact same thing as a doctor within our speciality. And then from there, there's usually a second member of staff present. So we always have an assistant who is there for the patient as an advocate and also to assist us as a clinician. Firstly, we discuss with the patient their smear results. And that does vary from clinician to clinician, I must be honest, how much we're going to discuss. But we discuss what result they have, and then we give them an overview of what the examination will entail. And then we give them an opportunity just to ask any questions if they do have any, and take a history from them. And then following that, we then give them a private area to get changed. From there, then we assist them onto the examining couch, make sure that they're comfortable because they're often very nervous at this point. Then we usually instruct them with what's going to happen as we go along with the examination. Again, that does vary from clinician to clinician. Everybody's style does differ. But we use a speculum, we view their cervix. We use a colposcope, which we usually describe to them as a microscope on wheels. It doesn't touch them in any way. And then we apply liquids to their cervix, which allow us to see or identify any abnormal areas. We do have a monitor that we use, so we allow for the patient to be able to view this as well during examination, which I do personally find quite helpful for a lot of patients because they're often quite interested. A lot of them don't even know they have a cervix or what it looks like or what the expectation is. So I find it quite useful for them to be able to see this. And sometimes this helps to reinforce what it is that we're actually looking for in their examination. We take photos at our clinic just to keep on their file. And if required, we take a biopsy from them. Following that, we then apply a special paste to cauterize and stop the bleeding. Quite often, this is the point where many women do feel a bit of a cramping period-like sensation. And if we don't need to biopsy, of course we won't biopsy, and we'll explain to them that the examination looks normal. And then from there, they'll change again, and then we'll discuss the findings and when they should expect to receive their results, and just answer any further questions that they might have. Next slide. So I've just detailed quite a few questions really that people mainly asked. And I'm just beginning with HPV. Although we do discuss this in our when we're initially explaining to them about their results, quite often they still ask various questions, which you can see. So quite often the first question that they do ask is, my letter says I have high risk HPV, and does this mean that I'm at more risk of cancer? Quite often the patients are quite concerned, not about HPV in particular, but more so the fact that it states high risk, and make the assumption that this then means that they have something worse that is going to then lead to cancer. So as you can see, I've explained that HPV is a virus that causes cell change, of which that there's multiple strains, some of which are commonly found in a cervical cancer, and that the immune system will clear HPV at some point. And then following on from there, quite often a lot of patients, if they have heard about HPV before, it's quite often related to warts. So commonly they then assume that possibly they might have warts on their cervix, or that's what we're going to look for. Or they might say to us that I haven't seen any warts on my vagina on the outside. So we then would explain to them that HPV does have two types, low risk and high risk. And again, high risk types are commonly what cause cell changes on the cervix, which is what we're more likely to be interested in. And that low risk HPV causes warts, which doesn't really harm them in any way, just aesthetically not very pleasing to the eye. And this doesn't bring any harm to them. Also, that high risk HPV causes changes on the vagina and the vulva as well. We do sometimes inform them as well if necessary. Again, as you can see, so they quite often mention that when they go to their sexual health tests, that they didn't test them for HPV, and they sometimes assume that this should be tested for. So we make sure that they're aware that when you have a HPV test, usually this is tested for only on your cervical smear test, and that's what your cervical screen is for. And sexual health clinics do not routinely test for this. Again, just reinforcing that HPV, it's contracted by skin-to-skin contact, and this is essentially why you don't have that test at the sexual health clinic, because majority of people would most likely test positive for HPV. 4 in 5 people pick up HPV at some point. Next slide. And just continuing on with the HPV query. So I didn't see any symptoms. What should I look for? And they often ask, I haven't been feeling any pain. I don't see discharge. And they often want to look for a symptom or a sign for HPV. So again, we reinforce that HPV doesn't give you any symptoms. You shouldn't see anything from this. Don't look for anything. And again, that your smear test is what picks up HPV. Then they ask us, am I going to have a treatment to get rid of HPV? The answer is no. There's no medication for HPV. I think maybe this might be quite an important question. Perhaps maybe in the GP surgery, if you are discussing about HPV, just to maybe briefly mention that there isn't a medication for HPV, and if you do require treatment, because quite often they do assume that we're going to treat them, and just to reinforce that it's not for HPV, that's not what we treat them for. We treat them for the abnormality, and HPV is dealt with by the immune system. And as you can see, there's just a few other queries related to HPV. Not to go into all of the responses, but again, how long do I have HPV for? I haven't had sex for a long time. How did I get HPV? Same-sex relations as well. Quite often we get questioned about how did I acquire HPV, about condom usage, and if their partner's been unfaithful, and do they need to inform a partner or not. Next slide. So next is just regarding inadequate smears, or if HPV has been detected on a smear, but with no abnormal cells picked up. And ladies that come in asking, my results keep saying it's inadequate, which you have 3 smears. If inadequate, you refer to colposcopy. So just to again reinforce to them that if your smear test is inadequate, it doesn't mean that you have cervical cancer, or it doesn't necessarily mean anything or worrying as such. And the benefit of having the colposcopy is for us to reassure them and ensure that there isn't anything on their cervix that we need to be concerned about, and then trying to achieve an adequate smear test. Also, you can see as well, quite often when they come, they do question, oh, has my nurse not done my smear test properly? Again, we do let them know, no, your smear test has been performed correctly. And the reason why your smear test may be inadequate can be for various reasons. It doesn't mean that your smear hasn't been performed correctly. And as you can see, I've just stated there that it could be blood, inflammation, or just the anatomy of their cervix, hence why their smear test isn't being able to be achieved adequately. And again, you can see other queries, if HPV is on my screening test, should I be worried if I just have HPV only? And no, because again, HPV can be in your system, but doesn't necessarily cause you any problems. So nothing to be worried about, just means you might need to have a few more regular smears to ensure that that does clear. And following on from there, you can see I have had more than one smear showing HPV. What does it mean? How long will it take to get rid of the HPV? Which we know minimally takes 2 years, but can as well lie dormant, and for some people, they can continue to have HPV. And just moving on again to the next slide. So again, so when patients receive their letters, the generic letter that they receive detailing their results from the lab, again, another keyword that's picked up on that letter that they question is about dyskaryosis. And they often query this, they don't have any idea what that means. So the easiest thing to let them know is dyskaryosis means abnormality, and the types of changes that you might possibly get on a smear test can be borderline, low grade, moderate, or severe changes. And all of those changes are precancerous changes. And following on from there, you can see that with borderline and low grade changes, the way in which we manage those types of changes, usually we assess their cervix, and if there's no signs of any abnormality, quite commonly they are then referred back to the GP to have their smear test either in 3 years or 5 years. And that's provided we have an adequate examination, we can see everything completely and are confident that there's nothing missing. Then we will discharge them back to their 3-yearly or 5-yearly smears, depending on their age. And if we do see anything abnormal, we will then take a biopsy, and if that confirms low-grade abnormality, then they would then go back to a yearly smear again with yourselves. The next question following on from that would be, is the biopsy going to be painful, and can I have sex? And most women, they tolerate the biopsy. They tend not to feel the biopsy as such, but it's mostly the after effect that they feel pain, period-like pain following on from the biopsy. And we usually advise them to abstain from any intercourse or insert anything into their vagina for the next 5 days or until their discharge stops. Next slide. Okay, so just following on again, so the next type of smear result you might get is a moderate dyskaryosis, which is also referred to as a high-grade result. And sometimes this might be detailed in the patient's letter as well. So just so that they're aware that moderate changes and severe changes are both grouped as high-grade changes. But moderate changes and severe changes can be dealt with differently at times. Where with moderate changes, again, we perform colposcopy. We most likely are going to biopsy them if they have a moderate smear. And depending on their circumstances, we might monitor them every 6 monthly, or we'll recommend treatment. There are occasions where many patients are really anxious, having moderate changes, and don't want monitoring and will opt for treatment, and we will treat according to the patient preference if that's the case. And lastly, with severe changes, we don't sit on those types of changes. We do treat those changes. So quite often, many women come in, we'll biopsy them, and we'll arrange their treatment appointment on the same day. So they are prepared for that treatment on the next appointment. And in certain circumstances, we offer treatment on the day if it's an obvious high-grade abnormality. They will have treatment, but a lot of patients are not always absolutely happy to go ahead with that. I think it's probably more so from the preparation in their minds, coming in and having a treatment immediately. But in certain circumstances, we do provide that. And then commonly the question surrounding treatment would be that they're trying to get pregnant, and if they can continue with that. So it's probably difficult to discuss this initially in the practice, but in colposcopy, once they're there and we know that smear result, if it's a high-grade result, we often suggest to them that they await pregnancy, or just to wait for their results prior to continuing with pregnancy. We're more likely to suggest that if we're pretty certain that there's high-grade abnormality and we're likely to treat them. So we'll advise them to use condoms and, again, to pause on their pregnancy. But if they are pregnant and they come into the clinic with a high-grade smear, often we don't always perform biopsy, because quite often many women are very anxious about having anything done to their cervix while they're pregnant, and they think that this might disrupt their pregnancy. So we'll often just perform colposcopy, and if it is safe, we will just continue monitoring while they're pregnant. There are certain circumstances, very rare, but where we have provided treatment while a patient has been pregnant as well. But it does come with small risks. And there are other queries as well, which people do come with, which is more so surrounding family members, friends, and other things that they've heard about people who have high-grade abnormality, or especially in their family with regard to cervical cancers, then the assumption often is that they're going to have a cervical cancer as well.
Thanks, Dinah. Do you have any more slides?
Have I lost you?
Okay, we just want to leave time for Hannah as well, so thank you. Go on to the next one. Oh, I think, have you frozen? Are you okay? Lovely. Dinah, can you hear us? Yeah.
Yeah, I can.
Yeah, we can hear you.
Sorry.
Okay.
Okay. Just, I can't see the screen, so I'm not sure if the slide is on there, but the last slide was about glandular abnormality.
It's up there. We can see it. Yeah.
Okay. I can't see it, but just to say, so with regard to CGIN, or glandular abnormality, or as it's referred to on a smear test, you would quite often have a smear reporting glandular neoplasia of the cervical type. So if a patient has this type of smear, quite often they will come for colposcopy. They're likely to have treatment to their cervix. Initially, they'll have a colposcopy examination. Although biopsies are not representative of the abnormality, we may or may not perform biopsy, but we will probably discuss treatment options, and then following on from there, we'll discuss and review their smear test in the MDT and decide what the best suitable treatment would be for them. So that will be a LETS treatment, loop excision, or cone biopsy. And this is the reason why we perform this on glandular abnormality, is because unlike CIN, glandular abnormality is usually found further down in the cervical canal, which means that it's much more difficult for us to assess and monitor, and deeper in the cervix. So hence why we would perform treatment for diagnostic purposes and to ensure there's nothing further, cervical cancer or anything further. Next slide. I think this is the last.
I don't know if you can see the slide, Dinah, but it says referring to colposcopy as its title.
Yeah. Okay. So although our discussion is more so briefly that patient to colposcopy, which is with polyps, ectropions, or bleeding into menstrual bleeding, and any other unusual appearances to the cervix. Because again, quite often patients they have a cervical cancer again, or something related. Just to highlight, really.
We're losing you. We can't hear your audio, but I can. So I'll just remind you. Can you?
Not cancerous. Ectropions are not with HPV.
Okay, Dinah, we've lost your audio, so I think what we'll do is, thanks very much for that really interesting presentation. If you have a look at those sets of emails, I'm going to ask Catherine to post those emails in the chat so that you've got access to them, and say thanks very much, Dinah, for that really interesting presentation. If we can move to Hannah. Thanks so much, Hannah, for coming and joining us from Joe's Trust today. So Joe's Trust specifically is focuses on cervical cancer. I'll leave you to introduce yourself. Thanks so very much for coming.
You're so welcome. Hello, everybody. I hope everyone is well today. Thank you for having me. I think Amanda's going to share my slides for me. I work for Joe's. I'm obviously my pink t-shirt because I'm so proud of where I work. I'm so passionate about what we do. So whenever I can wear pink, I will. I've been with Joe's for about 4 years now, and I work in the frontline services, so on our helpline. More recently, I've moved over to our specific cervical cancer one-to-one support with those that are living with and beyond cervical cancer, and our email service, which is an extension of the helpline. That's also a new one that I'm working on, and also we have another one called Ask the Expert, so where people can email in and we send those on to an expert panel member. So in those various formats of service users that we have, today I'm sort of going to be giving an overview of the kind of things that we get on our helpline and across our services. Mainly, obviously, today's topic about screening, but obviously inevitably HPV does come into that quite a bit. There is quite a bit of a crossover between mine and Dinah's questions, because I think along the way we all get asked similar things from people. So if I could have the types of calls, please, Amanda, that would be great. Yeah, so these are just some of the most commonly asked questions that we get across our services, and then I'm going to talk about a couple of them that are really the ones that we sort of get every day. So as you can imagine, we get lots of questions on the helpline about screening and screening age. So we get asked sort of by people that are under 25 that have symptoms, you know, why they can't have screening. Certainly during the pandemic, we've got a lot of people asking us, how long is it going to take for my results? You know, please tell me. I think they think that we can access those sorts of things when, you know, obviously we can't do that. So we have to explain that, you know, we can't access that. And the big one, what is HPV? As I said, I'm going to pull out at the end of this slide these ones in a bit more detail. I've been married or in a relationship for years and I've always had clear smears. So why have I got HPV now? What is HPV primary screening? I've had a hysterectomy and I'm still being invited to screening. Very topical at the moment, which what's happened in Scotland. I've been invited to colposcopy, but I haven't had my screening letter yet. What does this mean? What will happen at colposcopy? And will I be having treatment at colposcopy? So obviously we get asked a heap more questions, but in a nutshell, they're the most common ones that come up for us. So I'm not going to go over HPV too much, as we've had quite a lot from Dinah, which was really, really good, and echoes all of the things that we get at Joe's. But around the HPV side of things, I would say what our callers are really concerned about is they don't understand the difference between high risk and low risk. They think they've had this on their result and then all of a sudden they're going to get covered in warts overnight. So that's something that we unpick and to us sort of help to unpick with them. Again, like Dinah said, they sort of don't understand if they've been for a clear sexual health screening, how this has arrived in their lives. But also what feeds into that is sort of the difference between HPV and HPV primary screening is they think that this is a brand new virus that nobody's heard about. So they've gone on to, as somebody referred to earlier, as Dr. Google. And by the time they get to us, they're sort of thinking, where's this virus come from? So it's only been in our lives for the past few years because that's when primary screening has sort of arrived, kind of thing. And when we explain that it's actually not that new, but the way that we look at the smear sample has changed, and you explain that, you can almost feel the relief that this isn't this terrible brand new thing that's just arrived. And you know, certainly unpicking HPV is something that we spend the majority of our time doing, I would say. The other thing is that when people have been in a relationship or a marriage for many years, and they've been for completely clear smears, and then all of a sudden, you know, this virus has appeared on their screening result, and that can be really, really difficult for the caller. And also sometimes we do get the caller's partner's phone after they've, you know, after they've had their result, and the sort of the overarching feeling is, has my partner been unfaithful? Where has this come from? Surely it can't have been there for all this time. And trying to unpick that, I keep saying unpick, that's the only word that's coming to mind at the moment, but unpick, you know, that their queries and their concerns as to how this could have happened for them. I would say this one has been more common I have been invited to colposcopy but haven't had my screening letter result yet. What does this mean? Throughout COVID, so we were seeing more of these because unfortunately colposcopy was letter and invite was arriving before the actual screening result, and that's obviously very difficult. Thank you. Obviously that's very difficult because we want to, obviously across any of our services, but the helpline is really close to my heart. We really want to reassure and support our callers, and it's so difficult to say this could be because of this, this and this, but equally if their screening letter doesn't stipulate what cell change they have and it just says abnormal cells and they haven't had their screening result, why they've been invited, you can't really gauge how that's happened. So if they've had it and it says on their colposcopy letter a bit more about it, or again, the pandemic threw things up for us here at Joe's because you could gauge perhaps what cell changes somebody might have if they were seen within 2 weeks, or if they were being asked to come in 6 weeks. Obviously, you can't guarantee that, but it can give you maybe some guidance. And you can, we would always be very, very careful about saying that we can't tell you this for sure. We're not medically trained. And also, we would never undermine the treatment, and each colposcopy is different, so they might not have a wait list at your one, so you're seen really quickly even though you've got low grade changes. But we were able to gauge things a little bit better during the pandemic. That just all went out the window because everyone was just trying to do the best that they could do. But generally speaking, lots of worried people who have gone onto Google, looked things up, so many inaccurate things online for them. And a lot of ladies and people with the cervix have never heard of HPV until it's come into their lives. So they arrive at us. What is this? And I would like to say that Tanya, the way that you explain what you do in your practice is what everybody should be doing, because yes, you have got such a short period of time to get such a large amount in there. And you're quite right in saying that people perhaps might not take it on, but we do know that that doesn't happen everywhere. And ladies sort of go in, have their appointment, and for the most part are very supported by their screening nurse, and they don't generally have a bad experience at all. But they don't hear about HPV at that appointment. So if it comes along on their result, they've never heard about it. And then they're frantically looking through the materials that have been sent to them, and perhaps ringing us or the cervical screening help desks throughout the UK countries, that kind of thing. So that sort of in a nutshell is the sort of common things that we get asked at Joe's. Can I have my next slide, please? Thank you, Amanda. So the sort of emotional impact that can have on our callers is the levels of anxiety and worry are huge. We get very, very emotional callers who are really distressed and nervous about their sort of results. They don't know whether to tell their partner, they don't know whether to tell friends or family. They can often feel quite alone, even if they've got a big support group. I spoke to a lady the other day who has wonderful friends, but she said, I don't feel comfortable speaking to any of my friends about this because I must be the only one. And when I sort of said, well, actually, now that we're open and we're going for meals again with people, if you went with 5 of your friends, 4 of them would actually have had a HPV or will have one at some point in their lives. And she just couldn't believe it. She was so surprised that this wasn't just her that was going through this. But the screening process itself can be quite difficult for people. And as somebody said earlier, you've done well, you've been going to them, good for you for actually going to them, or if you haven't and now you have decided to, that's brilliant. So you can imagine when they have gone through that they then get this result, how that can impact and how distressing that can be. We've also had the added wonderful layer of our lives, the COVID pandemic, which has just heightened anxiety to another level. So people that haven't been anxious are now anxious, and those that have already had anxiety, it's just been heightened threefold. And also we've had lots of calls from ladies who know they've got HPV and are waiting for their 12-month follow-up and want to know how the actual pandemic could affect them with having already having a virus. So that's certainly affected a lot of our callers, and people have sort of been really nervous about what the future holds. Like, what will this look like? How long will delays last? Will they be able to go to screening? All of a sudden, those people that didn't want to go are now nervous because they know that they perhaps couldn't get an appointment, and they're sort of kicking themselves that they just not took it for granted, but will just book when that feels good for them. And then the pandemic arrives and it's like, oh, I can't book now, and there's mass panic that you can't get in. So it's had sort of so many different impacts on our service users, and so we've really had to sort of adapt our knowledge and delivery, shall I say, on sort of how we do support our service users, which leads lovely, that's not a word, leads nicely onto my final slide, please, Amanda. So so how have we actually handled this? So what do we do? Yep, it's really difficult. Our sort of reaction to the pandemic was reactionary. We had to literally overnight get our materials together, try and be as up to date as possible, up to date and up to our knowledge base as much as we could, with all of our volunteers as well that work on our helpline for us, to make sure that we were actually helping in what was the most unprecedented times I think we've all had to live through. So our reassurance, it was really odd because we didn't have the answer quite a lot of the time in the early days. We just didn't know. When will screening open? We didn't know. There was lots of differences between the UK countries, so there's knowing all of that information as well. Trying to explain to people why your cousin down the road can have their screening and you can't because you're at a different GP surgery. Why might that have happened? Again, why they've got their screening result letter and you haven't, and trying to sort of just reassure in any possible way to make them feel better about why this might have happened. And we, you know, like I said, we really did have to gather ourselves and report to service and duty with the updating of all the knowledge, because it was changing so quickly in the early days, and even then going through different lockdowns, local lockdowns, national ones, how that impacts on screening and screening results and getting sent to colposcopy and things like that. So a lot of our sort of ways that we dealt with it was giving relevant signposting. So back to GP surgeries, our Ask the Expert service was increased so much during that time, and also the help desks from the various countries that could perhaps give more information on policy and that kind of thing. But overall, just doing our best and trying to be there for people that needed it and that still do need it. So I hope that's helpful and I haven't sort of crossed over too much with the people before me. And obviously I'm happy to take any questions if anybody has any.
That's absolutely fantastic, Hannah. Thanks very much. So yeah, let's move to some questions. We have got to an hour now. I'm going to let the questions run for a little bit because there's been lots of activity in the chat. We've got some questions there. Do stay with us if you're able to, and we'll just spend 5-10 minutes answering questions if people want to bring those now. But we understand if you have to leave, and you'll see the full. Be able to access the full webinar on the YouTube channel as I posted earlier on. So does anybody want to, I think if I go through the questions, one of the things that people have had difficulty with, and I just thought you might want to talk about this, Tanya, is the people have had an HPV self-screen, it's positive, but they don't want to go on and have a smear. I think this is something that several of us will have encountered. Can you tell me how you manage that, Tanya, and then I'll go to Hannah and see what experience she's had.
Yeah, that was quite confusing when it first happened. So I felt I needed to be armed with the information of being able to explain that to my patients. But if I don't understand it myself, how am I meant to explain it to them? So I called the lab and had a lovely chap who explained it to me. and basically he said that the U-screen is being tested on a DNA platform, whilst the normal screening is tested on an RNA platform. And what the difference between them was is that you could have a positive self-swab that picked up a DNA of possibly an old HPV infection that hasn't maybe just kind of a reminiscence of it remained, but there is no active infection on the cervix. Therefore, we don't have to worry about it, and there's no need for further testing. So I kind of got that I explained that to every lady, whoever offered the screening to. Number one, I always say, listen, that they have to understand that if they accept the U-screen and if it comes back positive, then a full smear is needed afterwards. So it's not just an optional something that you do instead. If it comes back as positive, we'll have to do to make sure that the cells are nice and healthy. Yeah. And then obviously, of course, if it comes back that it was first positive, then they're negative, and they look at me, go like, well, what does that mean now? And then you kind of have an explanation for them.
I think the thing that's really important for people to understand at the moment is that the way that we're running the U-screen trial at the moment, it is a trial. And so we're using that to collect data. We're going to close the study at the end of the year. Then we'll be analysing the data in the first part of next year, and probably won't go to publication until Easter or summer of next year. After publication, that's what will decide ultimately Public Health England, help them decide whether they move to rolling out U-screen as an alternative or an optional alternative across the country, but we haven't got there yet. So we've had fantastic, take up in North Central London of the invitation for practices to join U-screen. And in some boroughs, we had nearly 100% of practices joining, but the offer for take-up has closed now. So if you didn't respond when you were first invited, then you can't be added to the study at the moment. And that's just where we are with that. We can't run that or in any other way. That's what the system's like. But I agree, people need to be aware that they're using a trusted system. The data internationally is really positive around U-screen, and it's particularly good for people who've refused to ever undertake any other type of screening, but that at the moment they might well also be asked to do a smear, and that's just how it is. So in my experience, if you explain it like that, most people will then accept the smear. It's just only a small number of people who won't, but we just have to work within those parameters at the moment. Hannah, have you got anything else to add to that?
I mean, in our on the helpline, we haven't had as many inquiries as we thought we probably would have with U-screen, but we were very lucky to have some fantastic training on this in beforehand. I think with anything on the helpline, it's really good to use an example that is outside of their question. So it could be something like, it's almost like if you went and had a blood test and something was found and then you didn't go on to have the rest of that. So if you had, say, a deficiency in something and then the GP was saying, well, you need to have this to help with that, and then you don't want to do that part, it's part of, it's two stages. So the beauty of it is, if you don't want to go to screening by using U-screen, you can prevent that if you have a clear U-screen result, but you have to understand that if you don't, the next part of it to get that full screen would be a screening test. So I've spoken to a couple of people that weren't going to the actual trial, they were elsewhere in the UK but wanted to know about it and what would happen, like, and what it's about. And as you said, Claire, I think it's only a few people, once you explain, when they say, oh, actually, because it's kind of like, if you're not going to do the full thing, then why would you take part in the first part? But it's just the knowledge part. If you don't know that and you don't fully understand it, then it can feel a bit scary and a bit like, but what's the point in me doing it then, because I don't want to go for a smear test. But if you explain what that means and why it can be such a benefit, most people are like, oh, okay, that makes sense now, and like, okay, I probably would do that then. So I do think it's all about knowledge and making it relatable to people.
Yeah, absolutely. Absolutely. And sometimes, because of the subject matter, I find that people don't always declare what their real query is at the beginning. and so it's really important to be very open when you speak to patients and ask them, are there other areas they want to talk about, and even prompt them. Because you know, they may feel that they shouldn't be asking certain questions, or the questions are too sexually related and they're not sure, and this, that, and the other. So it's just about being open and assuring them that you're prepared to have a dialogue about anything. And there's a question in the chat there that Dinah answered, which is perhaps something, you know, related to that in a way. Somebody asking if they've only ever had oral sex before on them, does that mean that they're sexually active or not? Therefore, should they have screening or not? And the answer is yes, and Dinah explains why. But that's an example of a type of question that people may not come forward with immediately because they're not quite, you know, they may, until they really know a nurse or know a doctor, they may not talk about oral sex at all with them. Yeah. Any other questions? I've seen quite a lot of activity in the chat about women with LD, learning difficulties, and Fanda has said that we will be we're developing some sessions for that, and we are doing. But the other thing to signpost people to is that we've worked with MenCap to produce a really good video aimed at, it's designed and focused on patients with learning difficulties, about screening in general, and there's quite a lot of information in there about cervical screening, also about other types of screening, but also about cervical. So Catherine or Fanta, if you could post the link, if you're able to get access to it quickly in the chat, that would be helpful. But if not, for anybody else, we have it. You can access it through the website, I think, Catherine, and then onto our channel already. And that's a really good short video to signpost people to. It's actually about 20 minutes, so it's longer than most of our videos, but most of the people speaking on the video are actually local patients to our sector who have LD. So they're describing their concerns, worries, advice, understanding of, and the experience of having screening in their own words. Thank you, Catherine. She's popped something up there already. Brilliant. Can either Tanya or Hannah or Dinah, are any questions that you've seen or you picked up, or areas that you want to add now?
I think there is a question about the open exit and repeat in 3 months. I think that's just basically because there is nothing else that they can put in there apart from 3 months. But we always just say that there is no need to kind of, usually if I send a text out to say your HPV has come back, cells has come back positive, I will include straight away an appointment for the screening, with a kind of saying at the end as well, like, you know, if this is not a convenient time of day, just kind of let me know, respond back, and I'll call you back and we'll rearrange. So, but most ladies come back. Yeah.
Okay, great. Okay, so that's really good. I think we've had a really good session today. I'm just going to end with one. I want to draw people's attention to one issue that's come up, which you may or may not be aware of in practice, in that recently Public Health England unfortunately sent some text messages to a whole cohort of women, it's quite a large number, across the sector, asking them to come for their screening, but they got the dates wrong. Public Health England got the dates wrong, and so some of the wrong women were invited, and they came for screening too early. Now, we found out about that error actually because a practice nurse let us know that they had seen a couple of people presenting early with messages, text messages from the department, just, you know, asking them to come early, and in fact there was an error. So what we've been asked to remind everybody, and we will have had emails out about this, but I'm just going to reiterate it, that when you look at your cervical screening list in advance of the day of doing the test, ideally, if you could please take the trouble to check those women against Open Exeter, and if you think a woman is presenting too early, please will you contact her, to ensure that she doesn't have symptoms, because some women present early because they have symptoms. So if she doesn't have symptoms, could you just redirect her to the correct date for when she should come back and present for screening? If she does have symptoms, then obviously she needs to see you or one of the GPs in the practice and to take that forward. But the thing that you need to remember is that if the screening is done and it's done early, the Public Health England have an arrangement with all the laboratories, and the laboratories nationally destroy the sample without analysing it. So we've had lots of dialogue about this, particularly because in a way, this particular time, it's the NHS's or Public Health England's error inviting women early. And the last thing we want to do is to have invited them early. They've come and had their smear and then they've had the sample destroyed. But at the moment, that is what is happening. So please, if you wouldn't mind, double check the Exeter dates. If something doesn't add up, then don't do the smear until you're sure there's another reason to be doing the smear at that time, which probably there won't be. Probably it's an error, so the lady just needs to be rebooked. And what I would say is if you could possibly rebook them and actually give them a forward date, that would be really helpful, because we do get feedback that women, when this kind of error happens, the thing that they find really annoying is that they can't even be given a new date to book, but they have to call into practice, and that people find that difficult because it's hard to get through to general practice. So if you're moving a lady backwards in terms of her screening date, if you could possibly give her a forward date, that would be really helpful. Thank you. Right, I think I'm just scanning the very last messages, and everyone's just saying thank you for a fantastic talk to all our three speakers. So absolutely, I second that. Thank you very much for joining us, everybody. We had huge numbers of people attending, and we look forward to seeing you soon. If you want any other areas of cancer that you'd like us to cover, just pop that in the survey feedback, or put it in the chat if you prefer, and we'll pick that up and we'll make sure that we include sessions focused on the areas you want to hear about. Thank you very much. Thank you.
Thank you. Take care. Bye-bye.
Bye-bye. Bye. Bye.